Jasmine. I'm a trainee student. I'm still a student nurse at the moment, not fully there yet. But yeah, I'm also part of the Highgate and Highbury unit in London, and I'm the unit training lead there as well. So it's been I've got quite a couple of connections to St. John that I'm going to incorporate into this evening as well. But yeah, thank you guys so much for having me. It's really nice to be able to talk about how I get here and hopefully show you guys another pathway that St. John can take you down as well.
So we happy to start asking questions then?
Yeah, fire away.
So firstly, why did you want to become a nurse?
So it actually started during COVID. So I was furloughed from my job for about 6 months. And I've been volunteering with St. John since 2018, so about 4 years at the time. Well, no, 2 years at the time and 4 years now. So whilst I was furloughed, I decided to use my time wisely. And I volunteered to become part of the EAC program. So I trained up from advanced first aid to emergency ambulance crew. And I learned to drive the ambulances too. So I can now drive 50% over the speed limit. It's a great skill, I think, and very fun. But I really, really enjoyed it. And so through the EAC program, I not only was then working in London and going to people's houses and collecting them, taking to hospital, discharging on scene, but I also volunteered at the Lincoln Fire and Rescue Centre. There's a week-long it's like HEMS and heart training week during every summer. And it was just really inspirational to see that these nurses and doctors were doing kind of pre-hospital care, which is what I was experiencing on the ambulances too. And it just felt like nursing was a really good way to go. Whilst paramedicine obviously is fantastic as well, and I did think about that too, I felt that nursing had a couple more options and other ways to go and specialisms. Like, I could go into kind of neurosurgery or, I don't know, thoracic stuff, whereas paramedic, it's very much more pre-hospital care unless you go a bit further. And I thought with nursing, I could also do HEMS and heart. So hopefully you guys all know that. So HEMS and heart is like the helicopter emergency medical services, and heart teams, can't fully remember the acronym, but they basically go and they do emergency extractions, and they use helicopters, and they go and kind of rescue people from dangerous locations and collapsed buildings and things like that. So yeah, I just sort of want to go into a kind of dynamic work environment and have a fulfilling job, basically, away from museums, which I loved, but I thought healthcare was maybe my next goal.
So how long does it take to become a qualified nurse then?
Normally 3 years, but I have been super lucky because I did an undergraduate degree already in archaeology and anthropology, so a bit different. And then also my St. John time has really helped because I had 500 hours built up over the 2 years that I'd been volunteering. So that counted towards the hours that I would need in practice to complete the training. So I'm actually doing a 2-year condensed master's course. So I'm doing 3 years squished into one, which is a lot of work in quite a short amount of time, but it saves me $9,000, which is quite nice. So you can do it quicker in some ways.
What is the most common injury or illness you deal with then on a daily basis?
So I'm currently doing a theatre placement, so I'm in surgeries all the time. And at the moment, the one I've seen the most commonly is it's come in as appendicitis. So I've watched some laparoscopic surgeries. So laparoscopic sort of means that it's like keyhole surgery, basically. So they make 3 holes in your abdomen. One has a camera in, and the other 2 have little kind of crocodile pincers that can pull and push bits out of the way, and they blow you up with air, so your stomach actually expands, so there's space to move around and see inside. But actually, when they've gone inside the cases that I've seen, it's never been appendicitis. They've lifted up the appendix with these little pincers and just gone, that looks completely normal and fine. So the cases that I've seen, it's actually been sort of gynecological issues or something to do with the intestines. Someone had very bruised intestines that were bleeding. And then, yeah, it's just like kind of blood in the abdomen is an interesting one. It sort of obviously causes pain. So I suppose the bottom line is that actually it's not appendicitis that's the most common, but abdominal pain, because of course, as we all know, there's so many organs, so many things that can go wrong in there, and it's so hard to what's the word? Decide what's wrong. What do I mean? Not decide what's wrong with them. Diagnose. There we go. Began with a D as well. To diagnose lots of the issues that are going on. So I guess in some ways it was easy or better that they did a laparoscopic keyhole surgery to get in there rather than cutting someone open fully. Which, whilst I would have loved to see, because open it up like a book, you can see everything. For the person to not actually have an appendix problem, just to have 3 small scars instead is probably a bit better. And the top one, actually, it goes, they lift your belly button out and they go in through the belly button, and that's where they put the camera. It's so cool. Would 100% recommend if you can look up a laparoscopic abdominal surgery, because it's amazing what they can do.
How often do you see patients with mental health issues, and how do you treat them?
I would say reasonably often, to be honest. So considering, I think it's 1 in 4 people experience a common mental health problem every year, and we do see quite a number. I think my experience definitely reflects that. So yeah, 25% of my patients will be experiencing a mental health problem. It's not necessarily why they've come in to see us. There'll be some people who've come to A&E who are experiencing a mental health crisis, and that could be kind of coming about in terms of kind of a self-harm injury, or if a self-neglect or things like that. But also it might just be an aside issue. So they've come in because they've broken their arm or something, but we also need to bear in mind that they might be on certain medications for other things. They might not necessarily be able to take the best care of themselves if they're going through a mental health crisis otherwise. But I think certainly has been one of the most interesting cases that I've had was a man who was brought in to my ward from A&E. So when I was on care of the elderly ward, and he was brought into me, and the nurses handing over said, "Oh, be careful. He's very shouty and very loud, and kind of waves his arms around quite a lot. Just be mindful. He's a difficult patient," which is a word that we absolutely hate to use about people, but it's a difficult one because we want to warn our colleagues as well for their safety. We want to say, "Oh, just be warned because this person might lash out." But we never want to label patients, certainly because in this instance, when I looked back over his notes and I had the time to sit and read about him, it turned out that he had diagnosed schizophrenia. So when he was shouting and trying to hit things, he was shouting and talking to people that I wasn't able to see, or things that I wasn't able to see. So it was a real lesson, I think, in learning how to not necessarily ignore colleagues, but I don't know, make your own decisions about the people that you're confronted with in a medical situation, because you never know what's going on. And whilst it can be scary when someone's shouting and yelling at you, there might be a reason for it. And even if it's not mental health, sometimes, if someone's drunk or if they're scared or in pain, lots of these things can cause erratic mood behaviors and reactions. So I think whilst I do see mental health quite commonly, it's not necessarily always known to us, so we have to make our own judgments. But it's really important to have a good understanding of all the different things that someone could be going through, and just be as, I guess, kind and patient and calm as you can. And in that instance, I was actually able to make friends with this patient, or maybe not friends with the patient, but we were kind of on good terms because I was just really calm. And when I went into the room, I sort of waited for whatever was happening to pass. And then, I'd ask a question or ask if he needed anything. And if he'd go, what, I don't, because he was also still hearing other auditory hallucinations or maybe seeing visual hallucinations. So it's just about staying calm and, repeating yourself and being patient to try and kind of give them the time to understand you and process what's going on, because it's very hard for them to necessarily distinguish between what's real, real in the sense that I also experience it and will for him. And yeah, so that's quite an extreme instance of a mental health issue. But yeah, he'd come in for something completely different. He actually had bowel cancer. And so, but it obviously meant that the mental health issues that he was experiencing were contributing to how we were able to treat him or not. So getting him on the right medication for that was then one of the steps to getting him on the road to recovery.
What happens if a patient that does not have capacity refuses medical treatment? Can you overrule them or like act within their best interest?
Yes, so it depends why they lack capacity. So, for example, a child is not able to consent or deny some medical treatments like a surgery. So one of their nominated adults will do it, so parent or carer. But an adult is a bit more complex, of course. So in terms of thinking about vulnerable adults, I mean, everyone who comes to a hospital is vulnerable in some way because they're injured, they're asking for help, they need something from us. But in terms of capacity, of course, that can be impaired in a number of ways. So it has to be ascertained by 2 doctors, usually, or trained staff in the hospital who will come along and undertake a mental health assessment. Not mental health, sorry, capacity assessment, apologies, still on the last question. So capacity assessment, who, if they deem that the person doesn't have capacity, they put a best interests meeting in place, possibly with friends or family, or if the person doesn't have any, or we don't know to find them and we don't know how to do that, then it's a kind of multidisciplinary team. So the doctor, maybe an occupational therapist, physical therapist, nurses, dietitians, everyone who might have come into contact with them and have some knowledge about them in a different aspect of their life, and a social worker, often if they may have one of those. And so this meeting kind of helps us to decide what limitations we are able to put on this person if they need limitations, or what we can push for if we need to. So there's one patient who I had who did not have mental capacity due to a head injury, and she'd had a bleed on her brain, and then of course that had impaired some of her thinking and she wasn't able to make accurate decisions, but it had also impaired her swallowing, so she wasn't able to eat kind of regular food because she would choke on it, because she just didn't have the same swallowing ability anymore because her brain just wasn't speaking to her throat. And so what the doctors had done in the first instance was to give her, it's called a nasogastric tube, or an NG tube. So it's a feeding tube that goes up your nose and then all the way back down into your stomach. And you can just use a big syringe, and you syringe calorie liquids straight into people's stomachs. Because if you starve someone for too long, if food doesn't go into their stomach for too long, it kind of shuts down. So we had this NG tube in, but of course it's really uncomfortable. You have this tube sticking out your nose or one of your nostrils, and she kept pulling it out. But of course, without it, we weren't able to give her kind of regular food, even though that's what she wanted, because she couldn't comprehend why we were putting this tube down her throat and why she wasn't able to eat food. So what happened in her best interest meeting was something called a deprivation of liberty safeguards, or DOLS for short. So what it means is, so they deprive you of your liberty, but in order to safeguard you from yourself. So because she wasn't able to understand, we had to kind of protect her from her own actions of pulling the nasogastric tube out of herself. So in this instance, the DOLS enabled us to put very kind of giant mittens on her hands, and so sort of tape you into some gloves. So then she couldn't pull it out. What was really lucky about that was that it didn't last very long. As she was in hospital for a few days, the bleed on her brain subsided, and luckily it wasn't permanent damage. So she understood what was going on. She got her swallowing abilities back, and the DOLS could be revoked. But the DOLS also only lasts for about, I think, 24 to 72 hours, depending on what it's for. Because in the same way, as we learn about capacity and consent, capacity is only about sort of one decision at a time, or consent is for one decision. And so, of course, it has to be reviewed to make sure that we're not depriving someone of their liberty without means or when it's not necessary. So it always has to, be reviewed by multiple doctors and nurses. And if someone thinks that the patient might be getting better, we can retract the doles or maybe have a re-review of the situation. But it's very complex if someone is lacking capacity, because obviously you want to do what's best for them, and it's very hard to know if you don't understand entirely what's going on for them, especially because in this instance she wasn't really able to communicate her needs and her wants, her cultural background, her religious beliefs, all these things. There were many factors that could have influenced it. So all we could do was what we thought would be the best, and this instance certainly was feeding her. I think that's a good baseline. Feed people always.
So what happens then if you have a safeguarding concern at work?
So if it's a safeguarding concern, so in my case it would probably be to do with adults, because I'm an adult nurse specialty. I've not dealt with children in this instance. I think the first thing I would do is to try and speak to the person. So if that's appropriate, depending if they've come into work, into the hospital where I work, with an injury which looks like they couldn't have done it to themselves, or it's just a bit suspicious, then when taking a patient history, I would ask them about it and maybe probe and say, that doesn't necessarily sound quite possible. Like I understand this is what you're saying, but is it possible that maybe someone pushed you, or maybe these things happened? Obviously, don't want to be too leading with questions as well. But sometimes that can also be harder if there's another person present, or if the patient doesn't speak English, in which case you have to try and get the patient alone, get language line on the phone if possible, and try and get them in a safe and comfortable space to talk about whatever they might be going through. And if it's particularly difficult, I would probably get my supervisor to come in, so get the ward sister or the matron to come and have a review of the case as well, because often they have much more experience and many years on me, so can ascertain whether or not this is just me being, I don't know, overly cautious, or if it's actually a cause for concern. We have security on site if there is someone who needs to be removed, patient or otherwise. But then the safeguarding concern would be logged in the system. It would be raised with the national safeguarding team. Police might be called to investigate, and we've had police come to the ward before, and they'll come and interview a patient to try and understand what's going on, especially if they might have said something in passing which maybe implicates one person particularly. They'd come and get interviewed about what they said. So as nurses, it's very important to always be aware of the conversations that we have with our patients, and what kind of subtle meanings of things that they say, and ways that things could be interpreted perhaps. So obviously you don't want to go too far, and call the police in any little thing that they've got a cut on their finger or something. But it's a difficult line to tread, definitely. But luckily I'm never on my own. I've always got an adult who I can ask for help and check in with.
How often do nurses work with external agencies like social services?
Social services, not too much, depending on the ward and what's going on. But external services, so whenever someone's discharged from the hospital, will certainly be, the hospital will certainly speak to the care home or a district nurse or wherever someone's going to. We have a homeless team who deal with homeless patients or people experiencing homelessness who might come in, and how we can discharge them safely, especially if they want to go back to the street. So social services, possibly more in pediatrics, again with the safeguarding aspect, and again with adults in the safeguarding aspect too. But I actually don't know too much about this one, so I've never had interactions with social services. Yeah, I'm not sure how many people on my ward do otherwise either. Sorry.
Do nurses have to learn like BSL or Makaton? How do they help disabled casualties like that can't speak or use sign language?
Yeah, so we don't have to learn BSL or Makaton, which I think is terrible. I think we should at least have a basic course or something. So, I mean, I actually know how to say it. It says, welcome to the hospital. So you do sort of welcome and then a cross on your arm. That's also the sign for nurse as well. So kind of welcome to the nursing area, I suppose. So it's welcome to the hospital. But I just learned that because I was interested. No, I think it would be really handy. But so the way that we are accessible is we have things like language line if someone speaks a different language. British Sign Language isn't something that we tend to have interpreters for that I'm aware of, but I think often that's because we might be able to write down the things that we want to say to someone if they can't hear us. If someone's been deaf or hearing impaired for a long time, they're often very good at lip reading, which has been a problem with masks and COVID, of course, and certainly we shouldn't rely on someone being able to do something. It's not inclusive particularly at all. But I think we can ask for an interpreter. And in this instance, if they have a friend or relative that can interpret for them, even during COVID when it was a one-person policy, I think they were allowed to come in as well. I don't know if paramedics learn Makaton, or maybe even pediatric nurses might do, because I know that Makaton's often used in nurseries and receptions as well. Again, from a past life in a different career as a teacher, I learned a little bit of Makaton. So sit down was a good one, very useful for children. But yeah, I don't know. I think staff should know the basics, but unfortunately, it's not offered as standard, which is a shame.
So, do you ever work in the field with paramedics?
Yes, not as a nurse, not through the hospital or through my nursing degree, but have done with St John, which has been really lovely and certainly gave me another push towards this career. I'm mostly crew with a nurse though, actually, on the ambulances, which was very aspirational, because him doing nursing and also volunteering with St John and sort of seeing his trajectory was really helpful. But yeah, paramedics are great. There's some paramedic students in my unit and that come to my trainings, which is really nice. So I get their breadth of experience to add to my trainings. But yeah, it's good. They can do a lot more than I can as an EAC. I'm hoping as a nurse I need to become a nurse prescriber, I think, is my next step. So that's another course on top of this one. Then we could do bags of drugs, bags of blood. I don't know. Hopefully I'll crew with more paramedics in the future once I can drive fast on blues again. Yeah, so because during COVID we were able to crew under the London Ambulance Service. So because obviously COVID was a very busy time, lots of patients, lots of people needing ambulance transport. The London Ambulance Service wasn't able to, they couldn't handle it, but they were overwhelmed with the number of people that required transportation. So that was definitely a good time for my learning, certainly, and for being able to train up quickly and drive a lot around London. Obviously not great that there was a global pandemic going on, but it was very useful for me, and I think great for other EACs who then were able to give a lot more of their time and their skills back into the world, and not just at events, but day to day as well, which was really, really fulfilling, I think.
So how common is physical and or verbal abuse towards staff, and how do you deal with those situations?
Well, that's so it's not super common, but I have been hit twice, not very hard, but and I have been yelled at. So it has happened, and it does happen, unfortunately. But all of those instances, they were actually from people who were, obviously quite unwell. They're in hospital, that's why they're there. But these people were experiencing delirium and dementia. or dementia. So I don't know if you guys know the difference, but delirium is to do with a physical issue. So, you know, like if you're too thirsty, if you're constipated, you're hungry, or you're on new medication or something like that, it causes a brief altered mental state, which can affect how you behave. So some people go through very delirious spells and they hallucinate and things like that. Whereas dementia, of course, is a progressive disease and it gets worse over time, and can cause people to behave differently too. But so I suppose the way that I tend to deal with it is, you know, just go into another room, take a breath, and just remember the fact that it's not, you know, it's not me necessarily that they're angry at. They might be in pain, they might be afraid. You know, I don't necessarily know what people are experiencing inside their heads. And can be a bit difficult because it feels a bit personal. I've had people tell me that I'm really stupid and that I'm a terrible nurse. Like, leave me alone, go away. And I go, oh, I'm so sorry. I'm only a student. I'm sorry if I did something wrong. But yeah, it's just remembering that, you know, pain at the very minimum can make people angry and unfriendly. So let alone actual mental disturbance. So yeah, it's just remembering that it's not personal, and maybe sending another member of staff in as well and see if perhaps their personality gets on better. Maybe they prefer them to me. You know, everyone's human, and I certainly have my days as well. I get very hangry, terrible. So you know, got to be understanding as much as possible. And sometimes you just need 10 minutes and a cup of coffee, and then you can be back out there, and they'll be your best friend after that. You know, quick turnaround.
What is your proudest moment so far?
It's quite an embarrassing one because it's really small. Basically, day before yesterday, I put in my first successful cannula, which when you sent these questions through, that was the thing I was most proud of at that point. But so I stabbed someone and it worked, which was great, because the first time I'm afraid I actually just made someone bleed a lot. But that's my current proudest moment. But generally, overall, I think I tend to be proudest when I get good feedback, mainly from other members of staff. So it's lovely getting nice feedback from patients as well when they go, oh, that's so lovely. Thank you, darling, for giving me a cup of tea. But if another member of staff comments on something good that I've done, or, you know, they say like, oh, you know, you helped that patient when you know, you were rushing around and really busy, but you still took the time to do that. Or, oh, you did that blood pressure really quickly or really efficiently. And I think things like that are really helpful, and they make me feel like I'm doing the right thing, and hopefully on the right trajectory with my career and also kind of personal goals as well. It's something that's definitely made me realize that I need to do the same to other people as well. So I guess never underestimate the power of a compliment. I think especially in the workplace, it really goes an awful long way. And it makes me feel really chuffed if someone comments on something I've done well. And so I always try and pay that back. So if I notice that someone has been particularly kind to a patient, or they've gone out of their way to do something, then yeah, I try and comment on it and make them feel good too.
So the last question is, what is the most common question you get that you wish everybody knew?
That everyone knew the answer to. This is a tough one to think about, actually. So from patients, I think the most common one that I get that's a bit, not frustrating, but is, why can't you just give me, you know, X, Y, Z treatment? Or why can't you give me this medication? And then I'll be gone. I'll be out of your hair. You know, it'll be really quick. And I think what people don't understand is because it's not that simple. And often we can't just give someone a pill to make a condition go away, especially if, you know, they've self-diagnosed it by Googling their symptoms and Dr. Google has told them that they have one thing when, you know, it could be anything. So, I mean, yes, there are instances when patients are an expert in their own care. So usually chronic conditions, people tend to know what it is they've got and what they need. And that's fair enough. But often, you know, symptoms can be a sign of many different things. And so we have to do tests, scans, trial medications, things like that. So I understand it can be uncomfortable and frustrating when people don't immediately get what they think it is that they need. So I wish, I guess, everyone had an understanding of healthcare. Just a basic level would be really helpful. It's a bit like, I think everyone should work in the service industry and do a bit of time as a waitress or a waiter, just so you understand what it's like and you're not rude to them. I wish everyone knew just a little bit about healthcare, just because then, it'd make everyone a bit more patient, a bit more understanding, and I think a bit more confident in the care they're receiving as well, hopefully. Get them to place a bit more trust in the people that are looking after them. We have their best interests at heart. So yeah, don't get mad at us if we don't give you exactly what you want when you want it, basically. How do you get involved in HEMS and heart as a nurse/paramedic? Oh, that's a good question. So you have to have been in your career for a little while. I think you do a certain number of years sort of before you are able to train up. So you have to kind of prove yourself in certain areas. I know that anesthetics is a really commonly needed one because often patients need to be sedated at the site of an injury. But I don't mean sight on their body. I mean, like, if it's a road traffic collision or something, they'll need to be sedated on site and then they'll get airlifted out if they're in a bad way. So anesthetics, paramedics, both for driving and for kind of assisting, trauma doctors, so people with A&E experience, pre-hospital care, trauma, all of that. If you can get experience in that, that'll definitely put you in good stead. And then you can also do FEM courses as well, so pre-hospital emergency medicine courses, which can be quite expensive, but you can find other routes into it as well. But yeah, getting as much experience as you can of those things, and keep volunteering with St. John, I would say, because it definitely puts you in very good stead. You can kind of come on the HEMS heart kind of training sessions and see what it's about and do some networking. Networking is important in all careers and instances, I would say. So that's question 2. Tell us more about what you did before you started nursing. So I did my undergrad in anthropology and archaeology, which was super cool. I would definitely recommend it if you're interested in kind of humans historically and now, really. Doesn't necessarily put you in the best stead for a career, though. It's not a career trajectory. It's not like nursing or architecture or something like that. So then I ended up working in museums for a while. So I worked at the Jewish Museum, the Royal Academy of Music, English Heritage, National Trust, gone all over the place. My ideal goal was to be really good at pub quizzes. So I thought if I worked in every museum I could, I'd just learn lots of random knowledge. But I really enjoyed museums, did museum education for a long time. So with children, teaching them about, human history, about Jewish culture in some instances, about music. That was a fun one. I just ended up spending days singing with kids. It was great. Do love museums, but then it was COVID, unfortunately, that meant that I got made redundant because I'm sure you guys are all aware that museums were not, the arts didn't do super well during COVID. A lot of museums had to close down for a while. They're coming back now, but it gave me an opportunity to go into nursing instead, which I greatly appreciate as an opportunity. What does adult nursing mean? So when you choose to study nursing in the UK, they make you choose between 4 different strands. So there's adult, child, mental health nursing, and disability nursing as well. You can do combined courses, but generally before you start studying, you have to choose one of the 4, and then it kind of predicts what trajectory you'll take later on. I think mental health nursing is a really interesting one. It's definitely on the rise. I think people have started understanding how important mental health is. Certainly in the last year or 2, it's become a lot bigger. So that's what adult nursing means. It's not that I am an adult nurse. I'm a grown-up nurse now. No, I only nurse adults generally. So I'm choosing to do a couple of things with younger people as well, but generally I just look after adults. What subjects would be useful to study at school or college? Biology, 100%. I did not realize how useful my biology A-level was going to be. So when I started this, it was incredible. So having done a career in museums, starting again, age 28, I'm actually remembering things that I did when I was 18 or younger, 16, 17 at school. So the biology that you learn, about active transport across cell membranes is how drugs work in your body, and learning about the components of the heart, and how the blood pumps around, so which organ goes next, but then also how that relates to how cancer can spread in the body, for example. So the fact that the blood starts here and goes there means that if you have a blood clot here, it will then travel and go up here. So it's way more useful than I ever thought it would be, and I'm really pleased that I loved biology so much at school. I didn't do chemistry, but I hear that's very useful as well. But then anything you like, really. So my other A-levels were English and arts, which I think were really helpful in terms of, I don't know, just having a creative side as well, and being able to kind of problem solve creatively. And I think, I don't know, link with people in some ways. So everyone has, I think, some understanding of kind of culture and, artistic nature, which is nice. But yeah, sciences, unfortunately, it's probably the basic one. Oh, maths. Maths is useful if you want to be a nurse. You have to do drug calculations. So how much a person weighs, and how much water they should drink in the day, and if they've eaten food, and what this means. So therefore, how many pills should they take to make them go to sleep, or something like that. So it's, those kind of simplistic maths problems get a bit more complex when you're dealing with drugs that can possibly kill people. Yeah, maths and sciences, unfortunately, those are the ones that you do really have to do if you want to go straight into it. Do you find it tricky working shifts? Yes, in some night shifts. I'm a really bad. I'm not a night owl at all. But luckily, on the wards that I worked on, they gave us nap time, which was brilliant. It sounds a bit childish in some ways, having a nap time, but so I try and sleep before a night shift, and then have an hour's sleep in the middle, and then sleep for another few hours afterwards. Otherwise, I don't mind shift work too much, because you do 12.5-hour days during a week, so you do 3, maybe 4 of those on any day, maybe night as well. But then it means you've got a couple of days off to do whatever you want, really. At the moment, unfortunately, it's uni work and dissertation, but life admin, goodness, it's great. You can go and get your hair cut, or you can go to the shops when no one else is there because it's not busy. You can go and meet people for lunch wherever they work, which is quite a nice surprise for them. So it's tricky in some ways doing the night shifts and things like that, but I definitely do enjoy working only 3 days a week, maybe 4, depending on how it works. But yeah, that's definitely a plus, and I can recommend that sort of thing. But I think night shifts do tend to knock a few years off your life, unfortunately, because your body doesn't necessarily regenerate quite as well if you don't sleep. But that's how it works. You get to sleep back in the days, I think. How can I get practical experience before applying to nursing? So the St. John shifts have really, really helped. So my interview to get onto my nursing course, I used, all my examples were from St. John shifts that I'd done. I think do as many interesting ones as you can. I think, I was going to say nighttime economy, but I imagine you have to be 18 to be able to volunteer for that one. So maybe when you switch to an adult unit. But even, going to other events that are during the daytime, you know, you see an awful lot, and you know far more than other people will do when applying. The other option is to volunteer in or do paid work if you can get it in a hospital. So you could do stuff as an admin assistant, or you could do some portering, you could become a healthcare assistant. I would recommend that actually if you want experience to see if you like nursing or not. Maybe see if you could do some healthcare assistant work. Or in your local GP. So that's another thing that I did as well. I found out my GP surgery has drawing classes for people with aphasia. So that's people who've had a stroke and can't use some of their limbs or speak in some instances. And so I went and helped with that. They do bike workshops for people and who have other illnesses. And so I think if you look in your local area, I'm sure there'll be plenty of things that are healthcare related. And yeah, that would be fantastic. Anything you can do, which just is about helping people and showing that you like people, you get on well with them, and you care about them. I think those are the main things. As long as you can show that in anything you've done, that would be fab. Okay, nearly there. Penultimate question. What do you do in St. John? Okay. So I am an emergency ambulance, EAC, emergency ambulance carer. What did I just say? Can't remember what the acronym. An EAC. So I drive blue light ambulances, and I also treat people as well. So that's both at events and in the community. So when I sign up for community shifts, we basically get 999 calls handed down to us from central control, and we get category 1, 2, 3, or 4 calls. So 4 is the kind of least sick patient, and they can wait for 6 to 8 hours and they'll be fine. Category 1 is they're having a heart attack right now, get there immediately. And so yeah, so I can drive quickly around London with a person sitting in my passenger seat, or them driving if they can drive too. And we either try and discharge people at scene if possible, which is really good as a clinical experience, because you diagnose someone in their own home. So what's really important there is about history taking and figuring out, you know, why they actually want to go to hospital, and do they really need to, or is it just they're kind of scared or they're in pain and they think, oh, if I go to hospital, everything will be fine. And what actually might be better is that, you know, they stay in the comfort of their own home, and we give them some advice and tell them to go and see their GP or something perhaps, and save them the hassle of waiting around in A&E for hours. So yeah, ambulance work. And then also, so I'm the unit training lead for Highgate and Highbury units. So that means that every Tuesday we run training sessions. So either I run them or I get someone else to come in and do it for me. Preferably someone with more experience and knowledge than me about that topic. And yes, we have 2-hour sessions, and so volunteers in St. John, mainly from the Highgate and Highbury catchment area, but actually during COVID, a lot of the other units closed their buildings. So we now have pretty much everyone from our area come in, which is really nice. It's actually kind of a bigger group. And so I teach on everything really. If someone has an interesting topic they want to talk about, so we've done, you know, sepsis, diabetes, you know, basic life support, of course, the classic. I've had someone come in and do advanced life support, major car accidents or major incidents and how to deal with those. It's I think that's about it really. So just the training sessions. But it's good because it brings everyone from the unit together, and you know, you get time spent face to face, which means you know, when you go to an event and you see people, you can recognize them or plan to go together, which is great. So I'm really happy to be facilitating that, and facilitating. This is what I was going to say. Facilitating learning is so good for my learning as well. So especially if there's something at uni that I need to revise, I'll run a St. John session on it, because if you want to learn something really well, you should teach it, because then you'll get all the hard questions that everyone wants to ask, and then yeah, it just solidifies everything in your brain. So can definitely recommend teaching if you ever want to learn something really well. All right, final question. What advice would you give to a cadet who's thinking of becoming a nurse? Do it, I would say. I think it's fantastic. I absolutely love almost everything that I've done. And the people I've met are amazing. Nurses are incredible. They do so much for the community. And it's a really, really satisfying job. So definitely do it. Get some experience if you can beforehand. So yeah, the St. John experience is great. You guys already, obviously, you care about people, you care about helping, and you enjoy healthcare. So you're pretty much there, really. You're kind of almost nurses as it is. And have a look around. Maybe, oh, actually, one good one. Depending on finances. So if you go, you get a student loan for nursing. But the other option, if you don't want to go into debt, is to be a nursing associate, and it's a bit like an apprenticeship, and you learn on the job, and you get paid whilst you do it. So you kind of go into a ward, and they train you as you go. The other great thing about that, aside from the money that you save, I mean, is that you don't have to write a dissertation, which currently is killing me. So if you don't like writing 10,000 word dissertations, I think nursing associate is also quite a good one. And it's also good because you learn on the job as you go, and people are very supportive whilst you learn. So, not every learning environment is right for everybody. So if you don't think university is for you, then maybe nursing associateship is a good alternative. So have a look around at other training options as well. You don't necessarily have to go the kind of university route. I wouldn't always recommend it, depending on what your learning style is. Do junior doctors ask you for advice, and how does the team work together to help patients? So as a student nurse, I don't tend to get asked for advice, but I certainly offer it sometimes, which can be a bit nerve-wracking. But there have been instances where doctors have missed something, and I've read something on the patient's notes and noticed it. And it's really important that everyone feels able to do that. And it's made me feel very confident in patient care in general, in knowing that there are so many people that are part of a team that do work together, and everyone does their own little thing to try and help. And so if the doctor perhaps doesn't see something, then the nurse will see it, or if not the nurse, then the healthcare assistant, or if not the healthcare assistant, the physiotherapist, or the dietitian, or the occupational therapist. And it's good to know that there are lots of people around that will help sort of safety net every single patient. So I enjoy that one. But so yeah, I'd say always give advice. If you think you know something or think you see something different, definitely speak up about it, always. So why nursing rather than a paramedic, doctor, or midwife? That's a good question. I think my parents asked me the same. I just felt, so nursing I was able to do in 2 years, which I enjoy being able to do it quickly, because then I'll have another career before I'm 30, which is good. I don't know, it just felt like a threshold personally. Midwifery would be really interesting, actually. Having seen a couple of cesarean sections, I might be interested in doing that and maybe sidestepping into that in the future. And it definitely is possible to change once you're in. So from nurse to doctor, you can go and do a bit of a conversion as well. But I think it only saves you 1 year if you've done nursing in advance, because they do everything in a lot more depth in terms of their anatomy and physiology exams. There's just a lot more exams as a doctor, so you can slip in. You can go from nurse to doctor, but you don't save as much time if you do 3 years of nursing and then another 6 years of doctoring. It does take a very long time. So last one on this one. What do you wish you'd known before you started your nursing journey? Possibly how emotional it can be, because you often really care about your patients and you can really get to know them. And then something might happen which you are which is unexpected and that you don't want to happen, of course. but also there are so many opportunities and you meet so many wonderful people. And I guess, and you see so much cool stuff. And that's definitely, again, but I quite like gory things as well. So I got to, you know, I've been able to watch surgeries. I got to spend a day in the morgue, which is very gory. Very morbid, I suppose. But I've seen so many amazing things. And I kind of, I wish I would have started nursing sooner, I guess, when I was slightly younger and just had more time to enjoy it.